Well, thank you very much, and I'm very pleased to be invited. I want to start off by saying I couldn't agree more with Niall about the centrality of rights, uh, co-production, of course, but right at the heart of mental health, ever since its inception, um, some 150 plus years ago, um, there is a power imbalance between the service user, as you might call them. Certainly nowadays you'd call them service users. I think in the past that might have been stretching it, as most of them would not be voluntarily doing so. Um, but power and force and the rights of people is very much central now to people's thinking. And I've recently come back from the Global Ministerial Summit on Mental Health in Paris, which is the third summit, which was devoted to rights for people in mental health, as well as COVID. And I'm pleased to say that next year will be in Italy, where actually community mental health has been, and the whole debate around rights and human rights has been there since the 70s and 80s. So important changes. We haven't gone far enough, and I'm aware that probably the single most important harmful effect in mental health is a direct result of what we as professionals do in restraining people in inpatient units. And that obviously carries very significant risks. Okay, so I'm not going to be talking about that. I'm going to be talking about what we're doing at a policy level in addressing inequalities. And in particular, looking at inequalities for, I suppose, racialized communities. So first, next slide, please. So I'm going to look at very briefly at our advancing mental health equality strategy. I'm also going to look at some basic metrics around inequalities in performance. I'm mostly going to talk about the patient and carer race equality framework, which I have not produced, but I think is very important. It's been led by people like Jackie O'Dyer, along with others like Colin. And then as a postscript, just to give you a little bit of detail about our analysis of the patient and carer race equality framework. So next slide, please. Okay, so this is about advancing mental health equality strategy, which we have published, and you can get it online. I think that if you click on the link, it will take you there. But essentially what the advancing mental health equality strategy is about is, first of all, well, what are the sort of key supporting local systems have we got going? And that will include the patient and carer race equality framework, which we've developed. It's also things like we've got pretty much every program in mental health driven from the centre, so new money coming in, up to £2.3 billion. Each of those programs has a transformation pilot or set of transformation pilots. And for every one of those, we are asking each of the sites to say what particular aspect of equalities are they going to address. So we're trying to make sure this is an integral part of any change for the future. We're also doing work around provider collaboratives, and we're measuring, the provider collaboratives are basically taking what are currently specialist commissioned services like secure care or perinatal inpatient units or whatever. And these are all being repatriated to localities so people stay as close to home as possible. But it also means linking up those £2 billion worth of services to localities so that we can move towards deinstitutionalizing many of those services. Now, those provider collaboratives, one of the 6 measures that we're putting into, are you achieving what you're meant to be achieving? One of them is about inequalities. So we're doing it in there too. Now, we're also looking at data quality, and it's absolutely true. I'm sure a major criticism of where we are now, and have been for some years, although it's improving, is that the quality of data that we pick up from localities does limit our ability, our intelligence actually, about what actually is going on. But that is a major part of the work that we're doing, which is to improve data quality. And I suppose the third part of the strategy is around workforce. We want to get to a point where locally, every mental health workforce reflects the population they serve, in terms of serving those racialized communities, but also other groups. Okay, next slide, please. Now, the most important bits here, I mean, do read the stuff on the left at your leisure, but the 2 bits that I want to draw attention to, one is IAPT. Now, IAPT is the psychological therapies that you can get in primary care. There's about 10,000 therapists across the country, gradually built up over the last 15 years. Unique in the world, don't think there's anything quite like it. Now, what is especially unique about IAPT is that it's got some really very detailed and reliable data. One of them is recovery rate. So that's judged by measuring someone's clinical state when they come into the service on questionnaires in the main, and then measuring them at the end after they've had treatment. And the average is roughly about 51% of people have a complete recovery. Probably another 15% have a sustained improvement. But you can see in that top graph that people coming in who are white British have a better recovery rate than people from Black, Asian, and minority ethnic groups. So, and I'm sure that if you got a more detailed breakdown of those racialized communities, that you would find some would be worse than others. And it's worth bearing in mind on top of this, that actually access to IAPT is lower in a number of groups of racialized communities. Now, the bottom graph is about inpatient services. The blue line is for Black, Asian, and minority ethnic groups. The dark blue line is for white British. And you can see that for the white British, of all the white British people admitted, 15% of those admitted across the year have never been in touch with a community mental health service. Whereas for BAME groups, we're talking about being over 20%. So what that tells me is that racialized communities are not able to, or are not, for one reason or another, accessing community mental health services at an earlier stage, and thereby are being admitted as their first port of call. Not good. Next slide, please. Okay, this is the patient and carer race equality framework. And Niall, you have to tell me if I need to speed up. So this framework, there's 2 bits of work going on here. We've got 4 trusts which are listed there: South London, Maudsley, East London, Birmingham, Greater Manchester. We've got this patient and carer race equality framework, which has 3 parts to it. And we're asking those trusts to do 2 things. One, we're putting in a questionnaire about organizational competencies, which I'll come to in a moment. We're asking their staff and their patients, have we got this right? But we're also asking the governors of those trusts to have a look across their trusts and to see what extent they can get the PCREF, the Patient and Carer Race Equality Framework, into each part of their trust. In the long run, we want every trust to have their own PCREF. Now, the PCREF has 3 parts. One, is part one, statutory and regulatory obligations. And you might, this is my interpretation of it, you might think this bit is, if this was all in place, if this was fully accepted within a trust by all staff within it, we would be in an ideal position, and we would be able to say that racialized communities were no longer being racialized by mental health. So if we had the Human Rights Act, the Equality Act, the Workforce Race Equality Standards, the CQC well-led domain, etc., use of force, Mental Health Act, etc., you know, we would be in a very different position. Part two is to identify what are the organizational competencies, and we'll come to those in a minute. What are the core competencies that a trust has to have to be able to move to part one? How are they going to get to the point where anyone walking into the trust gets the same service, whatever their background? And the third part of it is, how do we assess this? And that's being led by Jackie and others. It's not Jackie on her own, obviously, but Jackie and others. And they've developed feedback and assessment tools which will tell us how well these organizational competencies have been taken up. Next slide, please. Okay, so those in the boxes, they're the organizational competencies. They were competencies identified by Jackie and her group within the Mental Health Act review. We think that there's a very good chance that they are the right kind of competencies around workforce, co-production, co-learning, staff knowledge and awareness, cultural awareness, and so on. Now, what we've done is we've put this questionnaire around, basically asking staff and patients in each of those four trusts, are these the right things? And you'll see in the bold bits below that of the 10 organizational competencies, staff and patients have told us that cultural awareness comes out as the most important. 76% said so. Partnership working, 67%, etc. And you can read the rest yourselves. Now, it's worth bearing in mind that the returns, we've had 289 questionnaires as of 4th of October, but 70% of those are from staff. So we are now looking to break down what's the difference, 30% carers and patients. But so if you go to the next slide, that will just give you a better sense of what this data really is saying. So look at the pie chart at the top, and you'll see that 67% of the returns are from professionals, 20% are from patients, 15% from carers, and 13% from others. And that basically will be voluntary groups, that kind of thing. People who've got a significant interest in mental health and are associated with that trust. And then if you look at the healthcare category by ethnicity, then you look and on the graph below, you'll see that so if you see the patient group, so that represents 20% of that 289, and you'll see the breakdown that the lowest two groups are white and Asian, and the largest two groups are mixed and black. And whereas you go further right to the professional groups, the largest return by a significant margin is from white professionals, and the lowest is from mixed professionals and then black professionals. So that just gives you a caveat about what this data is saying, but we hope to get much more data, and eventually we may be able to say something a bit more solid. But in any event, we are watching closely what these trusts do about seeing to what extent they can develop their own PCREF across their trust. So that's me done, I think.